Good morning, good afternoon, and good evening, esteemed professors, doctors, guests, colleagues, and participants from all over the world. Welcome to Measles and Rubella, a timely update for pediatricians, an international webinar conducted by the International Pediatric Association. For the smooth running of today's event, kindly pay attention to the following rules and regulations. Participants are encouraged to have their videos turned on throughout the webinar. Participants should keep their microphones off unless permitted by the moderators. And to obtain the certificate of attendance, participants are required to attend the entire duration of the webinar and fill in a feedback form which will be distributed at the end of the event. To officially open the Measles and Rubella, a timely update for pediatricians webinar, it is my great honor to welcome our first speaker, Professor Enver Hasanoglu, as the President of the International Pediatric Association. Without further ado, to the professor who needs no introduction, to Professor Hasanoglu, the time and screen is yours.
Dear colleagues and friends, I am Professor Enver Hasanoglu, the President of International Pediatric Association. As you know, IPA, International Pediatric Association, is conducting so many webinars belonging to our children's health. And today's webinar is on measles and rubella. As well known, measles is highly contagious viral diseases, and it is still an important cause of mortality and morbidity for children, especially in many developing countries. Although vaccination reduced global death caused by measles, about 73% dropped between 2000 and 2018 worldwide. But measles is still common, particularly in part of Asia and Africa. More than 140,000 people died from measles in 2018. The majority of these deaths occur in low-income countries. The number of reported worldwide cases has increased by 79% in the first 2 months of 2022 compared to the same day last year. Unfortunately, we noticed the ratio of measles case increased in Latin America region as well. Unfortunately, measles vaccination coverage has steadily declined since the beginning of the COVID-19 pandemic. In 2021, nearly 40 million children missed measles vaccine dose. 25 million missed their first dose, and additional 15 million missed their second dose. This decline is a setback in global progress towards achieving measles elimination, and leaves millions of children susceptible to infection. In 2022, there were an estimation of 9 million cases and 128,000 deaths from measles worldwide. This means that it is an important threat in every region. When we evaluate statistics on rubella, it was eliminated from United States in 2004. As of July 2020, 173 of 195 countries, meaning 89%, had introduced rubella vaccine to immunization program. Despite this progress, rubella cases continue to occur, and about 15,000 cases occurred globally in 2018. The difficulty of increasing the vaccine and the follow-up of vaccinated children depends on several factors. like COVID-19 pandemic. The disruption of vaccination may be because of irregular programming of primary health care services. Even COVID-19 is continuing. It must be our duty to continue on routine vaccination. Other reasons were wars and migration. This condition paralyzed health system. On the other hand, these children who had immigrated cannot reach vaccination in the countries they have to go to. I'm sure this webinar will be useful for healthcare and for our pediatrician, and our distinguished speakers and moderator will focus on this problem of vaccination of measles and rubella in details. Thank you and good luck.
Thank you very much, Professor Enver Hasanoglu, for your opening remarks. I now invite Dr. Mary Agocs as a member of the IPA SAG on immunization and the director of the Measles and Rubella program at the American Red Cross to give a brief overview of the webinar. So Dr. Mary Agocs, the time and screen is yours.
Great, thank you. Thank you so much and welcome. Welcome to the webinar. Thank you for taking the time to join us for this very important conversation. As we heard from the professor, measles and rubella continue to be with us. And as we know, measles anywhere is measles everywhere, given its infectious state. If you could go to the slide for the rundown of the webinar, please. It's my pleasure to, on behalf of American Red Cross, also welcome you. American Red Cross has been pleased to work with IPA in organizing this webinar. And what you see here, obviously, will be the rundown of the show. After my comments, Dr. Walt Orenstein will give us additional background to help set the global stage, which will then be followed by Dr. Patrick O'Connor, who will give us the perspective of a global update from the World Health Organization on both measles and rubella. This will be followed by Dr. Bill Moss, who will go into more detail about the clinical and epidemiological aspects of both measles and rubella. Subsequently, the next session will have a detailed look at tackling vaccine hesitancy. I believe in many of your pediatric practices, this is a topic that I'm sure you've dealt with. And so I'm sure you're all looking forward to learning about these evidence-based strategies that we'll hear to increase acceptance. I'll speak a little bit about the role of civil society and what we can do to help you and what you can do to help us also in terms of advocating for children to be vaccinated. And at the conclusion, we'll have a question and answer session. So again, thank you for joining. It's a pleasure of American Red Cross to formally open the session. And with that, I will turn it back to our MC. Thank you.
Thank you very much, Doctor. The next agenda of our webinar will be moderated by a very special and distinguished moderator. It is my great honor today to introduce our moderator for this webinar. Professor Walter Orenstein is a professor of medicine, epidemiology, global health, and pediatrics at Emory University. From 2008 through 2011, Professor Orenstein was deputy director for immunization programs at the Bill and Melinda Gates Foundation. Prior to 2004, Professor Orenstein has also worked for 26 years in the immunization program at the Center for Disease Control and Prevention. From 1988 to 2004, he was the director of the United States Immunization Program. He has a former Assistant Surgeon General of the USPHS. He's a past chair of the WHO's Poliomyelitis Technical Consultative Group and chair of the National Vaccine Advisory Committee. He is also currently the chairman of the World Health Organization's Immunizations and Vaccines-Related Implementation Research Advisory Committee. He has also been a past member of the Strategic Advisory Group of Experts Working Groups on Polio, as well as measles and rubella. Without further ado, to Professor Walter Orenstein, the time and place is yours.
Thank you very much. Let me share my screen. Thank you very much, and it's a real pleasure and honor to set the stage for our webinar on measles and rubella. Measles is a serious disease. It's highly contagious. It is the most contagious of the vaccine-preventable diseases. We have a highly effective vaccine to prevent it. It most frequently occurs in children, hence the importance of pediatricians. There is a classic rash and fever and clinical presentation. It is associated, unfortunately, with severe complications, including pneumonia, diarrhea, encephalitis, and death. And death case ratios vary from place to place, but the lowest death to case ratio was about 1 in 1,000 to about as high as 10%. There are severe complications, blindness, corneal scarring, particularly in areas where there are vitamin A deficiencies. Encephalitis, about 1 in 1,000 cases, often associated with permanent brain damage. The biggest killers from measles are pneumonia and diarrhea. Pneumonia is often bacterial and a major cause of death. In 2000, measles was listed as the fifth leading cause of death among children less than 5 years of age in the world, despite having a vaccine for measles since the 1960s. This is an article from the Morbidity and Mortality Weekly Report looking at the 2 decades between 2000 and 2020. And the bottom line is that almost 32 million deaths were averted through vaccination as a result of measles vaccination. The dotted lines being the actual deaths and the solid line being the projected deaths. Unfortunately, the vast majority of cases that we do see are what's called directly preventable. In other words, occurring in persons who should have been vaccinated but were not. Now, all the cases are truly preventable, the others through herd immunity if they're not exposed. But the big issue is to get vaccines into the bodies for people whom they're recommended. My favorite quote is, "Vaccines don't save lives, vaccinations save lives." The other issue with measles is that when you're going to see a problem with your vaccination program, measles is usually the first disease you see. And unfortunately, therapy sells more than prevention. And certainly the P in public health is political will. And the importance of political will is getting into the political support. And we used in the US measles, which was a vertical program, to build our horizontal program. In other words, a diagonal approach to use measles to build our overall healthcare delivery system. So what are the key characteristics making it an indicator disease? Again, highly contagious, the most infectious of the vaccine-preventable disease, a relatively distinct clinical syndrome, at least rash, illness with fever. Virtually all infections are clinically apparent. We have good tests. It's episodic in nature. And what happens is when you have an outbreak, measles goes down, people get used to the low levels and then get very concerned when it comes back up. And that's a way to get political help. And there's substantial complications, including hospitalizations and deaths. And this just shows you the basic reproduction numbers, which is the number of secondary cases that would occur if an infection was induced in a 100% susceptible population. And you can see here with a number of the vaccine preventable diseases, measles is at the top of the list, and its herd immunity threshold is calculated at 92 to 94%. The other disease we'll be talking about is rubella, and it's the leading cause of vaccine preventable birth defects. While the illness in acquired rubella is generally very mild, less than and as many as 50% of cases may be asymptomatic with no rash. There's a prodrome that's rare, but is seen in adults with low-grade fever, malaise, lymphadenopathy, and upper respiratory symptoms. And in the absence of vaccination, we should expect epidemics every 6 to 9 years. And this just shows you the big concern is when susceptible pregnant women are infected, particularly in the first trimester of pregnancy. And this is a paper from Liz Miller in 1982 showing that the big concern is early in pregnancy, which can lead to fetal death, premature delivery, and a spectrum of birth defects called congenital rubella syndrome. And this is an individual child in 1966 that had congenital rubella syndrome. 5 years later, severe developmental delay, cataracts, and deafness. And this is in 2005. And this is a totally preventable illness. The public health significance is before vaccine introduction, CRS incidence was 0.1 to 0.2 per 1,000 births, and higher during pandemics. In 2010, there were an estimated 110,000 infants born with CRS worldwide, and again, associated with serious long-term health effects, shortened lifespan, and major health costs. Kim Thompson, in risk analysis in 2017, published a paper showing the annual costs of this disease burden. And if we could get rid of both of those diseases, a savings of roughly $10 billion per year. So what do we need? We need to obtain political will to achieve measles and rubella eradication. We need to document the economic benefits of eradication. So a focus on eradication not only benefits measles and rubella, but benefits the whole immunization and the health system. And we need an additional champion. We have a great champion in the Red Cross, but we need more champions like Rotary and Gates have been for polio. And do we really need 95% immunity everywhere? Not everywhere, but in many areas. And again, this is where our healthcare system needs to reach out. So what do we need from pediatricians? Consider measles and rubella in the differential diagnosis of persons presenting with acute illnesses associated with rash. Obtain diagnostic specimens and send them to appropriate laboratories to confirm infections. Practice appropriate isolation procedures when suspected cases are identified. Report the cases with the vaccination status to appropriate health authorities to determine whether those cases are a result of vaccine failure or failure to vaccinate. Assure your patients are vaccinated as recommended. Work to assure every eligible child is vaccinated. Overcome vaccine hesitancy and take advantage of all opportunities to vaccinate. So a child who shows up with a minor illness that is not a contraindication who needs these vaccines, give those vaccines. Don't miss that opportunity. And advocate in the community for measles, rubella elimination, and hopefully someday eradication. Politicians, kids often are taken care of by pediatricians. It's very important for pediatricians to advocate in the communities and beyond their own practice. The topics that will be covered today are a global update on measles and rubella, a clinical viewpoint on measles and rubella, tackling vaccine hesitancy, a role of civil society, and then we have a Q&A section. With that, I'd like to then introduce our first speaker, Patrick O'Connor. And so let me stop my sharing. And Patrick is on the line. Patrick is really the Patrick is really the, if I could have the next slide, please. Patrick is the medical officer who leads the rubella and measles efforts at the WHO headquarters in Geneva, Switzerland. He had spent many years dealing with measles and rubella elimination and polio eradication in WHO areas and UNICEF and at the CDC in Atlanta. And with that, I'd like to turn it over to Patrick to tell us about the global situation.
Great. Thanks, Walt. And I will turn my camera off for bandwidth purposes. And if I could get my slides, please. Great. Thank you so much. And so I'm giving the global update on measles and rubella. Next slide, please. And so I'm going to talk about the epidemiology currently for measles and rubella, as well as some of the COVID-19 disruptions that we have seen over the last couple of years. Talk a little bit about vaccine cost effectiveness and return on investment, and some of the new tools that are up and coming, such as the measles rubella microarray patch. Next slide, please. And so this is a graphic showing the epidemiology from looking at the number of reported cases. And you can see it's divided by the WHO regions, the 6 regions in different colors on the right there. To note that in 2019, had the highest number of measles cases reported since 1996, and many of you may remember that being a very mission here. Next slide. Next, if you click again, please. And so you can see at the beginning of the COVID-19 pandemic, in sort of March and April of 2020, measles cases started to drop off, and there are a lot of questions about why a low number of cases. And so really it has to do with sort of 3 things: the natural immunity from those large outbreaks in 2019, all of those non-pharmaceutical interventions such as mask wearing and teleworking and travel restrictions that were put in place for COVID-19 also helped reduce transmission of other respiratory diseases such as measles, and that the vaccine preventable disease surveillance systems were disrupted and also diverted due to COVID-19, so that the number of, the ability of the surveillance systems to pick up
Patrick, you're cutting out.
measles cases was reduced. Next slide, please. Yeah. So I think currently what we're trying to prevent is a big uptick in measles. And so this is the same sort of graphic showing the distribution of rubella cases reported in WHO regions. And it's a very similar distribution as we saw for the measles cases, where at the beginning of the pandemic in 2020, the number of cases that were reported dropped off significantly. Could I have the next slide, please?
Patrick, are you still there? Patrick?
This is a graphic showing. Yep. Can you hear me?
Now we can hear you.
Okay. Sorry. Yeah. The bandwidth is quite low here. So to low number of measles cases reported in 2020 and 2021, measles did not have large and disruptive measles outbreaks, particularly over the last 12 months. Next, could you click again, please? If you could click for the next, yeah, and click one more time. Yeah, so there has been an increasing number of large and disruptive outbreaks, and the number of countries that have reported this indicator has increased from 19 countries to 29 in the last 6 months. So we're seeing a significant number of measles cases, particularly those that have been described as large and disruptive. Next slide, please. And click one more time. This graphic shows the surveillance sensitivity that is reported for measles and rubella. And this is the number of discarded cases per 100,000 population. And so countries that are achieving this standard, if we look at comparing 2019 to 2022, that 81 countries globally were achieving that in 2019, and only 63 are achieving the surveillance indicator in 2022. And so existing surveillance systems may not have covered yet from COVID-19, and many may not be capturing all of the measles cases that are actually out there globally. And if we look at the measles mortality model, which I'll explain a little bit later, that only or approximately less than 10% of all measles cases are actually being reported. So there are a significant number of measles cases out there, and the surveillance systems are not necessarily catching all of them. Next slide, please. And so one of the ways that we are looking at progress is to look at the elimination of measles and rubella transmission. And so those are the interruption of endemic transmission in countries. And you can see the top graphic shows measles and the bottom graphic shows rubella. And about 40% of countries globally have been able to interrupt transmission, globally have been able to interrupt transmission of rubella. So if you could click again, please. Click the next slide. Yeah, great, thanks. So the regional verification commissions and national verification committees are the bodies that are responsible for documenting and then evaluating the interruption of endemic transmission. And remarkably, those commissions and committees conducted a lot of work remotely and in hybrid models during the COVID-19 pandemic. And there's been steady progress towards rubella elimination, and that actually could be a pathway for achieving measles. And if I could get you could click for the next slide. Yeah. So one of the challenges currently is that 19 countries have yet to introduce rubella-containing vaccine, and 12 countries need to introduce a second dose of measles containing vaccine. And if you could click again twice. And so in order to achieve elimination, we need to have these countries introduce those vaccines. And you can see on the left-hand side, we have the countries that need to introduce measles-containing vaccine. Many of them have plans to do that, and those are the numbers in brackets, what year they plan to do it. And then the 19 countries on the right need to introduce a rubella-containing vaccine. So less countries have plans to do that. And I think, being able to accelerate that would be extremely helpful in our ability to achieve elimination. Next slide, please. So this graphic shows the routine coverage of measles containing vaccines. The top line with the red bubble shows the global coverage. And in 2019, it was 86% for the first dose and 71% for this.
Patrick, are you still there?
First dose in the graphic. Sorry about the
I think what you're really saying, Patrick, is that we've seen a substantial reduction between 2019 and 2021 first dose coverage. Second dose coverage is not ideal, but it's only 71%. Is that correct? Are you on? Patrick, are you still on?
Walt, it looks like he dropped.
Yeah.
Yeah, sorry, I got yeah, can you hear me now?
Now we can hear you.
Sorry, yeah, I dropped off there. Yeah, just to say, if you could click again on the slide. Try to go through this. If you could click again, please. Yeah, just to say that there's really been, with the drop in the last years, there's
Well, Patrick is trying to. Can you hear me now?
Yep. Can we get the next slide, please? So availability, insecurity, and then cancellation of vaccination sessions, campaigns.
I think we may need to move. Patrick, we can see the slide, but I'm not sure, we're not hearing you, or I'm not hearing you at all. Maybe we can go to the next slide, Patrick. What you could see here is the stress on healthcare systems that COVID has placed, and the need to have resilience in those health systems to respond not only with measles vaccine, but with all of the recommended vaccines. Patrick, are you there? Why don't we go to the next slide?
Yeah, thanks. Yep. Sorry about my connection. Yeah, if we could get the next slide, please.
Can we get the next slide, please?
And so, yep, if you can hear me,
No.
I will continue. Great. So this is just a slide that shows the sort of vaccine effectiveness for measles vaccines. And sort of the graphic here, your return on investment is the high.
I think the bottom line is what you can see here in Patrick's slide is that of all the vaccine preventable diseases listed, you could see the biggest return on investment is for measles, and something that would be very important to get rid of this disease, not only now but forever. Can we get the next slide, please? This is just new technologies that are being investigated. One is called microarray patches, or MAPS, and the data look very promising that eventually we'll be able to develop measles and rubella vaccines that could be administered in this very simple way. We don't have them yet, but the results so far are very promising. If I can have the next slide, please. And what we see here is the measles and rubella strategic framework covering this decade, ranging from 2021 to 2030, with the vision of a world free of measles and rubella, and the need to achieve and sustain regional rubella goals in each section. And that's where we need the help of pediatricians, is getting vaccines into people for whom they should be, are needed, and getting rid of measles and rubella forever. Next slide, please. And as shown here, Patrick, are you on?
Yeah, I'm back again. Sorry about that. And so, yeah, so maybe just to summarize on this, if you click one more time, that'll be the last slide. Yeah. So just to say that closing those measles immunity gaps in 2023 and 2024 need to be a global priority. And really, we need to do that to prevent the morbidity and mortality associated with measles viral infections. And we do need all of your help in being able to achieve that ultimate goal of eliminating and then eradicating measles and rubella. Thanks. Thanks, Walt, for helping me with my bandwidth and covering some of my slides.
Thanks for doing this. We really appreciate it. Our next presentation will be on a clinical viewpoint of measles and rubella by Bill Moss. And Bill is head of the National Vaccine Access Center at Johns Hopkins Bloomberg School of Public Health. He is really one of the world's experts on measles. I co-edited a textbook and we turned to him, and Bill has written the chapter on measles. He's a real expert. And I will turn it over to you, Bill.
Thank you very much, Walt, and greetings to all of you. I'm going to highlight some of the key clinical and epidemiological aspects of measles and rubella, and picking up on some of the points that Dr. Orenstein made in his opening remarks as well, and really trying to focus on what's important for pediatricians. So Dr. Orenstein mentioned that measles virus is highly contagious, and he commented on what's known as the basic reproductive number, which is a key metric in infectious disease epidemiology that captures the average number of secondary infections from a single infectious person. Now, measles virus is transmitted by respiratory droplets and aerosolized particles, so these particles can remain suspended in the air for several hours, and so one doesn't necessarily need to have direct contact with an individual with measles because measles virus can be transmitted through this aerosol route. Dr. Orenstein mentioned this high reproductive number here shown 9 to 18. It is context specific. And then that herd immunity threshold, which in a very simple calculation is 1 minus 1 over the basic reproductive number. And as Dr. Orenstein pointed out, this is as high as 92 to 95% for measles virus. And I want to emphasize that that doesn't indicate the needed vaccination coverage. That's the level of population immunity that needs to be achieved. And because measles vaccine is not 100% effective, as I'll talk about briefly, you really need even higher levels of vaccination coverage. And this is one of the reasons why the World Health Organization recommends 2 doses of measles vaccine. It's to get that very high levels of population immunity that are needed to interrupt transmission. Now, measles, as Dr. Orenstein said, has very characteristic clinical features. And what is shown on the left is kind of a time series of these clinical features. I'll walk you very briefly through that. And then on the right, photos of the rash and the Koplik spots on the buccal mucosa, these small white dots that actually precede the onset of rash. So measles begins with what are called the 3 C's. This begins after an incubation period of about 10 days to the onset of these prodromal symptoms. The 3 C's are cough, coryza, runny nose, and conjunctivitis. Then you get the Koplik spots, those pathognomonic white spots on the buccal mucosa. And during an outbreak, a very astute pediatrician can diagnose measles by observing these Koplik spots prior to the onset of rash. But obviously, most children with measles are diagnosed with this, with the rash. It's a morbilliform, slightly raised red rash that starts on the head and neck and then extends over the entire body. And you can see that there's fever kind of associated with the onset of the prodromal symptoms and extending out for the duration of the rash. What's really important for pediatricians to understand are the complications of measles, and really understanding that measles is not a benign childhood illness. We've talked about some of these, a keratoconjunctivitis or blindness, particularly in children with vitamin A deficiency. Measles can cause mouth ulcers or stomatitis, a croup-like syndrome or laryngitis. It can lead to otitis media. But as Dr. Orenstein said, the most common causes of death from measles, morbidity and mortality, are pneumonia and diarrhea. And the pneumonia can be both due to measles virus, it's called a giant cell pneumonitis, but more commonly due to secondary bacterial infections. And these lead to severe pneumonia, respiratory distress, and death. I'll just briefly highlight there are actually 3 neurologic complications of measles: an acute demyelinating encephalomyelitis that Dr. Orenstein referred to that occurs in 1 in 1,000 cases, a measles inclusion body encephalitis where measles virus actually infects the brain. This occurs in immunocompromised patients. And then a very interesting condition that occurs years after measles virus infection, particularly in children who acquire measles younger than 2 years of age, called subacute sclerosing panencephalitis, which is a progressive fatal neurologic condition with a defective measles virus in the brain. Now, this is I have a lot on this slide, but I just wanted to highlight one of the reasons why children who get measles are really prone to these secondary, particularly bacterial infections. And it's due to the immune suppression that measles virus causes. Measles was actually the first immunosuppressive disease. It was that phenomenon was described by an Austrian pediatrician named Clemens von Perket back in 1911, who noticed that children who were previously had tuberculin skin test positive developed anergy after measles. They lost that skin test positivity, so a defect in cell-mediated immunity. That was back in 1911, before we even knew that measles virus caused measles. There's been a lot of work over the years in understanding the various mechanisms through which measles virus suppresses the immune system. Those are shown on the bottom left. It's through a number of immunomodulatory factors, including directly targeting lymphocytes and killing those lymphocytes, and a number of other immunologic aberrations that occur after measles. But what's been kind of more recent over the past 5 to 7 years has been understanding that this period of increased susceptibility to mortality from non-measles causes, infectious causes, can extend out for several years. It was generally thought to be for several months. There was a population-based study published in Science that showed that this increased risk of mortality can extend for 2 to 3 years. So our measures of the impact of measles on child mortality are really underestimates if this is a widespread phenomenon. And on the bottom right, a paper from the same group that really looked at what might be driving this. And there's still more work to be done in this area, but the bottom line is that measles can cause what they refer to as immune amnesia. Actually, I see I made an error here, and that bottom paper is, I have the same title, so I apologize for that. But in that paper published in Science in 2019, measles caused elimination of 11 to 73% of the antibody repertoire, meaning that measles virus is thought to kill long-term memory cells and plasma cells and really wipe out prior antibodies that children have developed from infection or vaccination, placing them at increased risk for infection upon re-exposure. Now, rubella shares many of the similar clinical features of measles in that it's a febrile rash illness. It does have some differences, and Dr. Orenstein highlighted some of these. Whereas measles is almost always symptomatic, 30 to 50% of patients or children with rubella can be asymptomatic. Other distinguishing features are the fact that rubella more typically is associated with lymphadenopathy, particularly posterior auricular and suboccipital lymph nodes, and it can also cause a transient polyarthralgia or polyarthritis, joint tenderness, joint pain and swelling. This is more common particularly in young women, young susceptible women. You can see on the right the rash of rubella. It's very similar to the rash of measles, and these are often very difficult to distinguish clinically, and why we need laboratory diagnostic methods to distinguish them. The real serious problem of rubella, as Dr. Orenstein pointed out, is infection of susceptible women, particularly during the first trimester of pregnancy, resulting in, and as all of you know, the congenital rubella syndrome. During pregnancy, rubella infection of the pregnant woman can result in miscarriage, stillbirth, or birth of a child with multiple congenital defects. Some of the more common include deafness, cataracts, heart defects, but they're wide ranging. There's a very characteristic rash, as Dr. Orenstein showed you, this kind of purpuric rash, blueberry muffin rash that children with congenital rubella can have. But sometimes congenital rubella syndrome can go unrecognized and really only be diagnosed later in life, later in childhood. The differential diagnosis of febrile rash illnesses, obviously measles and rubella, particularly during outbreaks, and as I mentioned earlier, those need to be distinguished through laboratory methods. I'll talk about that. But other infectious causes, scarlet fever, parvovirus B19, human herpes virus 6, enterovirus infections, and adenovirus infections can all mimic this febrile rash illness that is caused by measles and rubella. There are some non-infectious causes. I included Kawasaki's here, recognizing we're still learning what the etiology of that is, or drug sensitivities that can also cause diagnostic dilemmas. So there's a fairly broad differential diagnosis of these febrile rash illnesses, but astute pediatricians, again, particularly during outbreaks, can diagnose these. But clinical diagnosis is challenging. Particularly for clinicians and pediatricians unfamiliar with the disease, and as the disease incidence goes down, fewer of our younger pediatricians have seen measles and rubella in many parts of the world, but not all, certainly. It can be challenging before the onset of rash. In immunocompromised and undernourished children in whom the rash might be absent or altered. This was particularly noted in children who are living with HIV prior to antiretroviral therapy and immune reconstitution, can have an unusual rash. That rash can be delayed, for example, or have a different phenotype, or actually be very desquamating. And in individuals with pre-existing antibodies, for a variety of reasons, they often have a less apparent rash that can be hard to detect, even though they have measles virus infection, because of this pre-existing immunity or pre-existing antibodies. Now, as we've mentioned, measles and rubella require laboratory confirmation because of it's not always clinically apparent. And the most commonly used test to confirm measles virus infection is detection of IgM antibodies by an enzyme immunoassay. One thing to note is that it takes several days for these IgM antibodies to rise and become detectable. So only about 3/4 of individuals with detectable measles virus will have detectable measles virus specific IgM antibodies within the first 72 hours after rash, but usually almost all will have detectable IgM antibodies after 4 days. So if you're testing early on, just note that you could have a false negative test just because it takes some time for these IgM antibodies to rise. Alternative diagnostic procedures include a 4-fold or greater increase in measles virus-specific IgG antibodies. These IgG antibodies arise after the IgM antibody, so you need acute and convalescent sera for that. But many programs will confirm measles virus infection with an IgM ELISA, but also collect a specimen for viral RNA. Usually those are nasopharyngeal swabs, but urine, the virus can also be detected in urine. And so this is another way to confirm measles virus infection using a reverse transcriptase PCR assay. And it also allows for genotyping of the virus, which can be useful for epidemiological purposes. And as Dr. Orenstein mentioned, all suspected and confirmed cases of measles and rubella should be reported. Now, when is measles virus and rubella virus, when are they infectious? And so one of the things about measles is that it does have this relatively long incubation period, which is the time from exposure to the onset of clinical symptoms. As I said, roughly 10 days to the onset of the prodromal syndromes, maybe 14 days to the onset of rash. So individuals with measles are infectious prior to the onset of rash. This makes isolation procedures a little less effective, I'll say, although certainly very important. So 4 days before the onset of rash till 4 days after the onset of rash. Airborne transmission precautions are recommended for hospitalized patients 4 days after rash onset and for the duration of illness for immunocompromised individuals. And exposed susceptible patients should undergo airborne precaution from day 5 after exposure until day 21 after exposure. For rubella virus, the infectious period is also several days before the onset of rash, maybe a little longer after rash onset, 7 days. Droplet precautions for 7 days after rash onset are recommended for postnatal rubella. Now, interestingly, children with congenital rubella syndrome can shed rubella virus for a long time, at least a year after a year of age. And so contact isolation is recommended for children with congenital rubella syndrome unless they have 2 negative RT-PCRs 1 month apart after 3 months of age. I won't go through, this is a really useful guide from the World Health Organization. It's entitled Guide for Clinical Case Management and Infection Prevention and Control During a Measles Outbreak, that was published in 2020. You can access this online, very helpful for pediatricians. I won't go through this whole algorithm for what to do when you have a child with suspected measles. I just want to highlight at the bottom, how you would handle a child with suspected measles in your practice, in your office. 1, give the patient a medical surgical face mask to wear. 2, isolate in a single room, preferably a negative pressure room, but understanding that most pediatricians don't have that. Collect samples, we mentioned that, the serum, urine, or throat swab for laboratory confirmation. Report it and conduct triage and prioritize admission of severe cases. I also want to highlight that for measles, one can use a post-exposure prophylaxis. So after exposure in a susceptible child, or particularly a child who's susceptible and immunocompromised, you can use measles vaccine within 72 hours after exposure to help mitigate the disease, or measles immune globulin up to 6 days after exposure if you have access to that. In terms of treatment, there's no specific antiviral agent available either for measles or rubella, but the World Health Organization recommends that all children with measles receive vitamin A. The dose is age dependent, that you can see here, whether it's 50,000, 100,000, or 200,000 international units. These is given on 2 days, for 2 days, the same dose each day. And then for children who have vitamin A deficiency, an additional dose 2 to 6 weeks later. Antibiotics are obviously, as we've mentioned, bacterial complications of measles are a major cause of morbidity and mortality. It is not recommended that all children with measles be treated with antibiotics, only if there is clinical evidence of bacterial infection, recognizing that that can be difficult to identify. But there are no recommendations for either prophylactic use of antibiotics or the universal use of antibiotics for children with measles, and obviously rehydration for children with diarrhea. For rubella, vitamin A is not recommended for rubella, but supportive therapy. But as we've said, it's generally a mild illness. Congenital rubella syndrome can be very complex and really requires the multidisciplinary team under the direction of a pediatrician. Briefly, there have been 3 types of measles vaccines that have been licensed and inactivated: a high titer and attenuated. The currently used vaccines throughout the world are attenuated measles vaccine, meaning that they were derived from a wild-type measles virus that was attenuated by serial passage in non-human cells. These are relatively heat-stable in lyophilized form and are administered parenterally. But as Patrick showed, there's a lot of excitement in the measles world about the potential use of these microarray patches that would avoid the need for needle and syringe and are potentially more thermostable, and so could be stored outside the cold chain for a longer period of time. Now, I mentioned earlier that measles vaccines are not 100% effective, and the vaccine efficacy really depends on the age at which the vaccine is administered. For children younger than 12 months of age, which would be in many of your countries, measles vaccine is around 75% effective, 75 to 85%, I'll say. In this study, 77% overall. If you administer that first dose in children over 12 months of age, that vaccine efficacy increases to 92 to 95%. So in countries with low incidence of measles, where you can afford to delay that first dose, you get a higher response rate. And then when you give that second dose, you get up even much higher, approaching that herd immunity threshold that's required to interrupt measles virus transmission. Rubella virus is also an attenuated viral vaccine that was attenuated by passages, again in tissue culture. Rubella vaccine actually has higher vaccine efficacy. It's 95% or more after a single dose. So that's one big difference between the attenuated rubella vaccine and the attenuated measles vaccine. Both vaccines induce almost lifelong immunity, although there is some waning over periods of decades. Rubella vaccine, because of that very high vaccine efficacy, could be administered as at least one dose, but obviously in most countries it's co-administered with measles vaccine, so children get 2 doses. Now, in terms of measles vaccine safety, the side effects of these vaccines are generally mild and transient. There can be soreness, redness, and swelling at the site of injection. These vaccines, because they're attenuated viral vaccines, can cause kind of diseases that mimic measles and rubella, although much milder. So maybe 5 to 15% of children will get a fever, sometimes associated with febrile seizure. 2% will get a rash. Very rarely is this transient thrombocytopenia that can occur. There are even rarer allergic reactions thought to be due to neomycin and the gelatin stabilizers. There's no increased risk of permanent neurologic sequelae, autism, or inflammatory bowel disease after measles or measles and rubella vaccine. And again, because these can mimic the disease somewhat, rubella vaccine is associated with arthralgias in about 25%, particularly in susceptible women, less common in young girls. The WHO position paper on measles vaccines, published in 2017, recommends that all countries have 95% coverage with 2 doses of a measles containing vaccines. The first dose, MCV1, can be administered at different ages 9 months or 12 months, depending upon the incidence of measles in that country. And then the second dose, which is really critical to achieving that high level of population immunity. Again, countries have different schedules for these, but generally 15 to 18 months of age when MCV1 is administered at 9 months of age. There are some situations where measles vaccine can be administered at 6 months of age. This includes outbreaks, refugees, and internally displaced populations, HIV-exposed children, and high-risk children. And obviously, many of you are familiar with the use of mass vaccination campaigns or supplementary immunization activities to decrease these, close these immunity gaps. And then lastly, I just want to mention that if you're advising children who are traveling abroad, very important that they receive measles vaccine. If a young child, a young infant, 6 to 11 months of age, is traveling to a setting or country where there is endemic measles, you could administer measles vaccine as young as 6 months of age. And I'll just end, Walt mentioned this, and Patrick, this idea of measles eradication. I won't go over this, but this has been discussed for many decades, but increasing discussion recently, and pediatricians can play a big role, as has already been outlined, in getting children vaccinated, but also a voice in the community to policymakers and politicians about the real value of eradicating measles. And I'll stop there.
On vaccine hesitancy, she's played a big role with the strategic buyers group of experts on vaccine hesitancy issues. And she's the person I turn to when I need advice on how to overcome vaccine hesitancy and build confidence. So take it away, Noni.
Thanks very much, Walt. I hope you can see my screen. There's no way I can cover everything that we know about vaccine hesitancy, but I want to focus on a few points that I think are really pertinent when we're going to talk about measles and rubella. The first thing is that the immunization agenda that's been set up for where we need to go with vaccines for the next decade was passed by the World Health Assembly in 2020, and then by all of the WHO countries later in 2020. And that includes all of you that are on the call. And the big point here was no one left behind. And that's part of what we've been talking about, is how do we try to get people that are being left behind with their family, their kids, for measles and rubella immunization. Well, vaccine decision-making is very complex. Lived experiences matter. What's happened to them in the past? Have they been disrespected? What's their lived history? We're strongly influenced by what we think others around us are doing or expecting us to do. And that can include social media networks and WhatsApp groups and other things. We see causation and coincidences. We see what we believe rather than believing what we see. We see what we want to see. We prefer anecdote and stories to data and evidence, and we're influenced by whether we perceive the disease as a threat. And we pay much more attention to negative information. So as soon as we're talking about side effects of measles vaccine or rubella vaccine, that may be heard more loudly than how bad the disease is if you get it and how effective those vaccines are. Therefore, safety concerns and lack of trust may be very prominent. And access can be very difficult, and that can affect how hard you're going to go to get that vaccine. So vaccine hesitancy was defined in 2015 by the WHO, and it's a delayed acceptance or refusal of vaccines despite availability of vaccine services. It's complex, context specific. It varies across time, place, and vaccines. So you might see people that are hesitant to get measles vaccine, but they're fine with DTP. that's influenced by factors such as convenience, complacency, and confidence, known as the 3 C's. I'm just going to zip over here for a minute. We know that the 3 C's didn't quite explain enough that was put out in 2015. The 5 A's came along with access, affordability, awareness, acceptance, and activation. And then the 3 C's morphed to the 5C model and eventually to the 7C model with all of those factors that I've noted here. And in 2022, the WHO working group with UNICEF came out with the behavioral and social drivers of vaccination. They emphasize the importance of what people think and feel, the social processes, the motivators, and practical issues. This document you can download at the URL that I've given you, and has lots of information for you, but it also has questionnaires that you can use maybe within your clinic practice or other groups to find out what the factors are that are affecting people's decision or not to accept vaccine. The problem that we had with this is that it's maybe not as it's maybe much more complex than these patterns show you. For this reason, the Royal Society of Canada developed a framework for looking at vaccine acceptance, of which hesitancy is a piece that is much more complex as this. And just as Walt said, you can have political reasons in the community why people are not accepting vaccines. You can have structural issues, how the clinics are set up that are barriers. You can have misinformation and disinformation in your immunization knowledge here. Healthcare workers may be undereducated. There may be some healthcare workers who know something about the measles rubella vaccine and others who do not. And the others who do not may be speaking up to the people in the community. You also have to have the context. Are we in the middle of a measles outbreak? Yes or no? What are the civil society organizations doing? What are the religious and community leaders saying? All of those can affect vaccine acceptance, as well as these other ones, what the communication strategy is, how a community is being set up, what's the education level. We know that those with less education are much more likely to not accept a vaccine. So based on that complexity, what I'm going to do here is talk a little bit. I can't cover all of the barriers, the structural, behavioral, and information barriers, but I'm going to outline a few of these in the small amount of time that I have, and then talk briefly about some of the interventions. So cost is a problem for some people. Yes, these vaccines are often free, but what's the cost for people coming to your clinic to get the vaccine? Do they have to pay for parking? How far do they have to walk? How easy is it to be accessible? What happens for your hours of operation? Do you only work Monday through Friday, no nights, no weekends, so that somebody who has to work in the daytime and bring their daughter or their son can't get there because they're going to lose money and may not be able to feed their kids? How far do they have to travel? If you have to walk 8 kilometers through Mud Pass in Uganda, for example, that's a pretty big detriment to getting there. Some places you have to book an appointment, and if you don't have an appointment, you can't get it done. And what about homebound individuals? If you have 5 children under the age of 6, what are you going to do with the other 4 when you're bringing your baby, your 1-year-old in? How's that going to work? And are there language and cultural issues that you're not addressing in doing this? How welcoming is the healthcare worker who's meeting this mother and child when they come to the clinic? Maybe poor infrastructure. We don't often have data to know who's missing. We know who came, but we don't know who's missing. And that may be what that's all about, is finding those little pockets. Have you looked at the data in your own clinic to see if all the kids that are a year old have had their measles immunization and their rubella immunization? Healthcare workers, excuse me, may not be up to date with the information that they need on measles rubella vaccination. That's why IPA has done this seminar. And we know that sometimes there's simple care system barriers. Stock out. You had that appointment, the patient came, you didn't have vaccine. Or when the patient came, there was vaccine there in the clinic, but there was no healthcare worker to give it. And we also know that reminding people to come forward to get their vaccine, regardless of whether this is a high, middle, or low income country, does increase uptake. Common behavioral barriers, data. As I said, we don't know who's immunized, who's under-immunized. And more importantly, and that's why I put emphasis on the WHO booklet I noted above, is why are they under-immunized? What can we do? What catch-up programs have been tried? Why have they failed? What have you done in your practice to try to catch people up? Did it work? Did it not work? Forgetfulness, reminders matter. Spirituality. A number of religions may be skeptical about science. This was particularly true with COVID vaccines, but it's also happened with measles and rubella vaccines. Inertia. That's why having you as the pediatrician recommend the vaccine is really important, as is motivational interviewing, which I will talk about in a minute. And bias and risk perception. What are the communication messages that you're putting out in your practice? What's happening in your district? What's happening in your community? Are these messages that are coming out from public health fit the population that you're trying to serve? Have they been tailored and framed in the way they need to be? I'm going to speak about that in a minute. So we need to use effective discussion techniques when we're talking to our patients. Presumptive, it's time for you to have your measles vaccine today, not participatory. What do you think about having measles vaccine? And then you open the door for questions and queries. What do you think about measles and rubella vaccine? And you listen. And then you listen reflectively. Sounds to me like you're concerned about, and then you affirm, I understand why that might be a worry. And then you say, can I provide you with some of the information that will help you better understand this, and then verify that they do understand. And then you summarize. And why do we summarize? Because most of us can only remember the gist of a conversation. We don't remember things verbatim. And then you finish with helpful to have a freedom establishing wording. Of course, it is always up to you. But you, by having done all of this motivational interviewing, have implied that these vaccines are really important for the patients in your practice. You need to use clear language, standard vocabulary. What do we mean when we say a side effect is rare? And we need to use that same common denominator when we're talking about side effects for the disease as we're talking about side effects for the vaccine. And you need to be truth-telling. You actually should never lie, because you'll be caught out on that. We also need to explain single event probability. If this child gets the encephalitis that Walt talked about, they are likely to be very damaged. You either got that or you didn't get it. You don't have a 1 in 1,000th of it. You either get 100% or you didn't get it at all. All right. And visual aids can sometimes help that. We need to be using absolute numbers, not relative risk and percents, because many people can't do those percents in their head. Fact sheets are very helpful, as are infographics. And don't use jargon. SSPE, most people have no idea what that is. So don't say, well, you have a risk of 1 in 10,000 of getting that, or it depends on the population, 1 in 1,000. That's not good enough, okay? Because SSPE is jargon. Timing and framing. We know it's far more important to say, positively, this vaccine has less than 1% serious side effects. And we need to say, because if I just say that, you don't hear that. It's better if I say it's 99.9% safe. All right. And the timing of the message, we have data that shows in randomized controlled trials that talking to a mother immediately after her baby's been born in the first 2 to 3 days, she's falling in love with that baby. Talking to her about vaccines and why she's going to need DTP and the other vaccines, as well as measles and rubella vaccine, at that time increases uptake of those vaccines when they actually need to be done, like at 2, 4, and 6 months and 12 months. And we need to be collaborating as pediatricians with professional societies like the IPA or your country's pediatric society, with the CSOs and NGOs like the Red Cross and other community partners, because the more people that are saying it's really important to get the vaccine, the more the parents are hearing that and how important it is to have measles vaccine and on time. Some of the other common behavioral barriers, the social norms. You need to work with religious community and political leaders. You have power as pediatricians to influence what these people are saying because you know the data and can make a difference. Lack of trust. You need to work on equity and respect in the system. You know how the healthcare worker introduces it, and the use of motivational interviewing can make a tremendous difference. Sometimes it's for the parents, lack of determination. Well, I don't really need to do this because there's no measles outbreak at the present. And I've never really seen rubella and or anybody with congenital rubella syndrome. Why bother? You need to make sure that access is easy. You need to reinforce the importance of vaccine acceptance. You need to address their concerns. And remember that you're telling your stories about what you've seen when measles has been there is very helpful. Data is important, but stories change our emotions, and we hear that more loudly. And then I cannot do this talk without talking about pain. Almost always people forget that parents many of them are afraid of needles. They don't like their baby crying, and we know ways to address that. Holding the child on their lap and breastfeeding them at the time you're going to do that measles immunization decreases the pain. RCT shown. We also need to address the common information barriers. So what do I mean by mis and disinformation? Misinformation is information that's false, but it wasn't created with the intention of causing harm. Disinformation is information that is false and was deliberately created to cause harm because they wanted economic gain. They were going to make money out of something they were going to sell you instead. Political gain, all right, or prestige, going to polarize. And often the disinformation message is simple, it's easy to remember, and it sticks. But the intention is to deceive the public. And when we don't have adequate information out to the public in ways that they can understand and preventing this from happening, you can decrease the amount of vaccine acceptance and make people not come forward for measles and rubella vaccine. So this was a paper that was recently published that just showed the categories of mis and disinformation: medical, scientific, political, media, and religious. And then the reasons that this laid into vaccine hesitancy: distrust of authorities, commercial profiteering, unforeseen future effects, personal freedom, and COVID denial. This was related to COVID vaccines, but the same would be true for measles vaccine. What's your job as a pediatrician is to help flatten that infodemic curve. If you have one less person who puts something up on WhatsApp or something up on Facebook, that helps to decrease this curve. So what can you do about this? The target is the general public. It's you're talking to the general public, as including the patients in your practice. This is called firefighting. And you need to be trained with others. And there is a good training program that you can go. Speak up. Remember, facts are the hook. Telling people that kids still die from measles. Share your stories. Be creative. Use humor. Highlight consensus. Look at all of this. All of these people think measles and rubella vaccine is really important. All of these scientists, all of these CSOs, and the religious leaders that you've worked with also are saying how important it is. The next step is fireproofing. This is where we inoculate the public against mis and disinformation. We tell them it's going to happen. We try to teach critical thinking and media literacy, and we show them the techniques that are used to sell mis and disinformation. And the WHO Euro has a good document about how to respond to vocal vaccine deniers in public and show the techniques that they use: conspiracy, fake experts, impossible expectations, selectivity. I'll just take a tiny little fact that actually belongs in a much bigger story: misrepresentation, false logic, and emotions. And then fire marshaling is getting your government to work on decreasing the misinformation that's on the social media platforms. One of the things I get often asked when I give a talk about vaccine hesitancy, somebody will say, but what do I do when it's my neighbor, my uncle, my father, my sister who's vaccine hesitant for their child? Speaking up matters, even in that social group that you're in, because we're strongly influenced by what we think others around us are doing and or expecting us to do. So if you as a pediatrician are silent in that setting, it sounds like you're supporting the people that are spouting forth the mis or disinformation or the false logic that's out there. And you need to say how important measles vaccine is and how important rubella vaccine is. And on that note, I'm going to finish with reminding you, as has been said over and over in this webinar, measles kills. Rubella can cause, congenital rubella can cause incredible damage. And we need to ensure that as many people as possible are up to date with their measles and rubella immunization. We have to control this. We have to get measles under control globally. And with that note, I will end my sharing.
Thank you very much, Noni. Our last talk is going to be given by Dr. Mary Agocs, the role of civil society. Mary is with the American Red Cross, and he has been involved in IPA immunization supporting global partnerships. Thank you very much. Mary, take it away.
Great, thank you. Just bring my screen up. So thank you again for welcoming me, and really appreciate the opportunity for American Red Cross to work with the International Pediatrics Association in organizing this webinar. And I wanted to speak with you today about the various roles civil society can play to help you in immunizing children, and also how you can help civil society contribute to the work that we do. And you may be wondering how Red Cross came to be here. And it really hinges on the slide that Dr. Walt Orenstein showed, which is copied at the bottom of this slide. Back in 2000, measles was the 5th leading cause of death of children worldwide. And we just, as an entity, thought that was completely inappropriate, given the fact that there was an effective, safe vaccine. And so we came together with the 4 organizations listed at the very top of the screen there, was US CDC, World Health Organization, United Nations Foundation, and UNICEF, to form the Measles and Rubella Initiative, which has now become a partnership, because we're very pleased to say that Bill and Melinda Gates Foundation and Gavi, the Vaccine Alliance, have now also joined in. And there are many other civil society partners. So I am here representing American Red Cross as a founding partner, but there's Lions, there's MSF, Médecins Sans Frontières. Dr. Orenstein mentioned Rotary, who's had such a pivotal role with polio. So I am going to give you examples related to what American Red Cross has done to support the work, but just noting, there are other colleagues who have also contributed. So what can civil society do to help you, and how can we best work together to vaccinate children? So some examples, and I'll sort of list these in as agenda of what I'll cover, and then work my way through and show some specific examples. We can help support communities. The Red Cross movement is the largest humanitarian global movement, and we have millions of volunteers in communities, many living in the most disenfranchised communities, who can be mobilized to share information, as Dr. MacDonald was saying, to work in hand with pediatricians to share the message. We can bring in our communications experts to develop media pieces such as opinion editorials or infographics, websites, videos to help tell that story. As Dr. MacDonald was saying, telling the story is so important. And we also, as civil society, can benefit from health staff, to serve as volunteers to help advocate and educate at all levels, at grassroots, at local leaders, the business, the religious, the respected individuals, and those all-important politicians who help promote and provide guidance and funding for various activities. So starting there with supporting communities, for example, what does this mean? So from American Red Cross side, you'll see there, we have contributed financial resources, technical support, and expertise. But I think most importantly, we've mobilized volunteers to work in 47 countries. So we don't do that. We work with the national society of that country. If it's Benin, the Benin Red Cross, if it's Mexico there, et cetera, to support vaccination activities, be it campaigns or routine immunization. And for example, most recently, since 2012, we've supported 59 campaigns, mobilizing over 82,000 volunteers, again, working at that local level to share your message of why it's important to vaccinate children, our joint message, if you will. We together have reached 20 million, almost 20.5 million households. That's the size of a country in many countries. And we've supported the vaccination of 38 million children. So very, very proud at what we've been able to accomplish, and looking forward to continuing to support. So moving now toward these communications materials, what kinds of things might these be? And these are just some examples of the information that we've shared. Starting there in the lower left, we, the president and CEO of American Red Cross, Ms. Gail McGovern, has banded together, if you will, with Kathy Calvin, who directs the United Nations Foundation. And this is one example of an opinion piece that was picked up by CNN. And again, this is noting so many children dying from measles. We've also had pieces around rubella for noting that for the importance of focusing on both diseases, but getting the word out and hearing it through different channels, raising awareness, if you will, is so critical. We also help support branding through our communications work, making those appealing posters, hopefully appealing, that, for example, you can put in your practice or that we can use on other materials, such as an infographic there that you see on the right. So there's this girl with the net in the middle, the measles moves fast, who's scooping up the measles red dots, rubella red dots. And that's then moved on to an infographic, which is hopefully a friendly way, rather than just providing, you know, a row after row of facts. It's hopefully an entertaining, catchy way to share information with the public and with parents when they're thinking about vaccinating their children and why. We also maintain a website on behalf of the initiative. Like I'm saying, we're changing the name to Measles and Rubella Partnership, and the website will change. So we'll share those specifics with you. But this is a one-stop shopping, if you will, to learn about measles and rubella. You can direct patients there. If you want, there's information about the disease, measles and rubella. There's a map of where there are outbreaks. Patrick had mentioned from WHO, Dr. O'Connell, the large and disruptive measles outbreaks are there. You can go there to see, you know, if there's an outbreak ongoing in your country as well. And then also an important role is using the civil society, health staff, and volunteers to advocate and educate. We work closely with our various partners to do this. You saw the list of partners on the previous slide, but we're really focused on eliminating and eventual eradication of both measles and rubella through the high vaccination coverage. And because of that, we work closely with our colleagues to undertake different advocacy programs. There is a World Immunization Week. So that's a global activity that takes place during the last week of April. And it provides an opportunity for all the partners and other stakeholders to highlight the benefits of vaccines and advocate for additional resources. So we work together with the UN Foundation and our other partners, and we work to educate Congress. We do that in different ways. We have testimony we submit when there are congressional hearings. We work very closely with the United Nations Foundation, particularly their Shot at Life, to organize a Hill event day. You see a picture there of some of the colleagues that are going to meet with senators and their staff to advocate about the importance of funding toward measles and rubella elimination programs. But there's also the really important grassroots advocacy, particularly the Shot at Life program that the UN Foundation leads. Shot at Life champions. These are, a variety of different individuals who provide key messages through their online networks and social media, people who are following them. And these advocates are sharing the message of the importance of being vaccinated. So sharing good information, hopefully on the internet, not just the misinformation and the disinformation. Also, civil society, particularly in American Red Cross, we have a network of nurses, some on our staff, some who are volunteers. They have a long history of supporting health activities, including helping to eliminate polio. And they have worked with us in measles and rubella since 2015. We have over 15,000 nurses in our American Red Cross network, and our other civil society partners have additional individuals. And we know nurses, health professionals, pediatricians are consistently ranked as the most trusted professionals in the United States. And so certainly your voice, the voice of nurses, really makes a difference. And it's really important, particularly for topics as Dr. MacDonald was noting, that can be controversial. We have, certainly for the nurses, really worked together to help raise awareness, not just for measles and rubella, but speaking about the strong immunization systems, both in the US, abroad, and providing education on how vaccines work, vaccine safety, and how to address vaccine hesitancy. So over the past 5 years, we've helped train nurses, trained over 90 nurses, and have conducted visits to over 50 different congressional offices during those years. So really proud of the work our nurses do, and noting it's not just nurses, but other health professionals such as pediatricians and others who can lend their voices to helping educate politicians. So really, in concluding, it is the healthcare professionals that are needed now more than ever in the fight against vaccine preventable diseases. We've heard during this webinar that COVID has weakened our immunization systems globally. We've heard vaccination rates have decreased in every World Health Organization region. Coverage has decreased with the first dose of measles vaccine to 81%, and almost 25 million children globally have missed their first dose of measles vaccine in 2021. And your role as a trusted health expert is invaluable, to share your firsthand experiences, to help educate, and to potentially work with civil society organizations, because you have a reach and influence that can extend far beyond your clinical practice. You are trusted and believed, and you know, there's many roles for you within your practice and beyond, should you choose them. Thank you.
I want to thank all of the speakers for outstanding presentations, and very important that we can get rid of these diseases, and we could also use them as a way to enhance our overall immunization programs and our overall health systems. We are running way over, so we do not have much time for questions. I think we can take a few, and I will cover them. One of them was, I think, Bill, you would be in the best position to address, is there a need to vaccinate children under 6 months of age if we're starting to see cases in that age group?
Yes, and this is, the optimal age of measles vaccination has been discussed for a long time. The current recommendations are, 6 months of age as the youngest age for measles vaccination by the WHO recommendations. When you start getting younger than 6 months of age, the proportion of children who will respond to the vaccine decreases markedly, and that's because of the presence of maternal antibody. And when you get to very young children, impaired other just immunologic immaturity, I'll say. So right now, the current recommendations are not to give measles vaccine younger than 6 months of age. There have been many efforts over the years to try to develop new vaccination strategies to do that, the high titer vaccine being one of them, but that had its own problems. But so I would say right now, the recommendations are not to administer the measles vaccine younger than 6 months of age.
And to add on to that, some people raised the question of should 6 months become the standard age for vaccination as opposed to 9 months of age.
Yes, and I think that's certainly worth a discussion. I don't think we have the data yet to support that, but what may drive that, Walt, is as more women of childbearing age have vaccine-induced immunity rather than wild-type immunity, they're going to have lower levels of antibodies, pass on lower levels to their children, and so that waning of maternal antibodies, which is really why we wait till 9 months of age, may be occurring, and we have some evidence, is occurring at younger ages, and so I think that's certainly a topic for discussion, but not the current WHO recommendations.
Thank you. I could ask Noni. One of the issues in terms of advocacy is it seems a lot easier to advocate on measles than on rubella. Do you have any recommendations as to what can be done to try and get the remaining countries to introduce rubella vaccines and to take rubella elimination more seriously?
So I'm going to say three things, Walt. I think one of the big problems in those countries is that there are people that fund the healthcare system have not and run the immunization program have not seen rubella as being such an important issue for them. But I think they have overlooked the congenital rubella consequences. They just haven't seen them and gone out and looked for them. And the more data we can collect from those countries that were listed by Patrick, the more we're able to be able to show them, you have a problem here. This could be prevented. And these children really have serious damage. But, you know, when you're out in a community where your birth is in a rural village, people may not see it at all or even recognize it. And I just think the biggest thing we need is more data. And pediatricians need to be yelling and screaming that we need to collect that data, because that is a preventable serious disability impacting disease. Over.
Thank you. And if I could add one more point, it's very important that even people, pediatricians in the high-income countries advocate not only for doing more to eliminate measles and rubella in their countries, but on a global scale. It's a win-win situation. It helps low and middle income countries, but it also helps high income countries because of reducing the risk of importation. We are one globe, one earth. And it's very important that, as Mary mentioned, the advocacy period, my own experience when I was directing the United States immunization program, is the American Academy of Pediatrics played a major role in getting us this support. And we had 2 presidential initiatives on immunization where we got millions and millions of dollars, and we built our system. I wrote that up in the Pediatric Infectious Disease Journal in 2006. But through the CSOs and professional organizations, pediatricians in particular played a big role in helping to make this happen. Unfortunately, we've run well over time, and so I think we need to move on to the next issue. I think the questions that I have were answered by the speakers in their actual talks, and so I'd like to turn it back over to Arnetta to lead the certificate session.
Thank you very much, Doctor, professors, as well as all our speakers and moderators. We extend our warmest round of applause and appreciation to our honorable speakers and, of course, to our moderators for the incredible and eye-opening presentations and discussion. As a token of our gratitude, we'll now present certificates to our honorable speakers who have contributed greatly to our learning process today. To present the certificate, we now invite Professor Aman Pulungan and Dr. Walter Orenstein. And to our speakers, kindly turn your videos on and smile as we spotlight you alongside your certificate.
Thank you, Dr. Connors.
Thank you. Patrick, the first one is for you. Thank you for your leadership over the years, and particularly where you are today, and trying to make elimination of these diseases an issue.
Thank you, Doctor. We'll now be
Great,
taking
thanks.
pictures. 3, 2, 1. Thank you.
Thank you, Professor Moss.
Thank you. Thank you, my pleasure.
I really appreciate all you have done and are doing and will do to help all of us get rid of these diseases and this health burden. Thank you so much, Bill.
Thank you all.
Be taking the photo. 3, 2, 1. Thank you very much, Professor.
And again, Noni, thank you for all you have done to build confidence in the immunization system and overcoming barriers to immunization, including hesitancy. Thank you so much.
Yeah. Thank you, Professor MacDonald.
Your pleasure to be here today.
I'll be taking the photo. 3, 2, 1. Thank you very much, Professor.
And Mary, very, very special. Thank you for actually being the inspirational person in getting this webinar set up, and all you have done and are doing to reduce the burden and hopefully eliminate these diseases in the future.
Yeah.
Thank you.
Dr. Yes, I think it's been, really nice collaboration with our office. Yeah. for preparing this webinar with you, Dr. Aida.
Yes, thank you. Thank you for working so closely. Thank you.
I'll be taking the photo. 3, 2, 1. 3, 2, 1.
Thank you, Professor Walter. It's been
It is my honor, and it's my honor to have had the opportunity to work with the people who presented on this webinar and the staff of the IPA who made this happen and have coordinated things in such a great way.
I hope if you come to India, we can meet in person
Great. Yes.
next month.
Thank you.
Thank you all.
I'll be taking the photo. 3, 2, 1. 3, 2, 1. That concludes the certificate presenting session. However, of course, no event is complete without a photo session. We now invite our honorable guests, speakers, and moderators to once again turn your videos on as we take the group photo. And to all the participants, kindly turn your videos on as well. We will take a group photo with all our distinguished speakers and moderators. Let us give a few seconds to wait for everyone to turn their videos on. Be taking the photo. 3, 2, 1. 3, 2, 1. We have quite a lot of slides. 3, 2, 1. 3, 2, 1. Slide 3, 2. That concludes the photo session of this webinar. Once again, on behalf of the organizing committee, we would like to extend our warmest round of gratitude and appreciation to all our speakers, moderators, and participants for making this international webinar a great success. To all the participants, kindly fill in the feedback form as detailed in the slide and has been sent via the Zoom and YouTube chat. The certificate of attendance will be shared via email upon completion of the feedback form. Furthermore, the International Pediatric Association also conducts routine webinars with a wide range of topics concerning child health. To keep yourself up to date, we urge you to follow IPA on our social media platforms as detailed on the slide. We have several opportunities for you to participate in IPA webinar and activities, but of course, the IPA will be having the IPA Congress next month on the 19th to the 23rd of February 2023. For more details, log on to www.ipa2023congress.org. IPA also provides various opportunities for healthcare workers to enroll in the IPA Vaccine Trust course to become a certified vaccine champion. The course is open to all healthcare workers for free. Refer to the post on the IPA website for more information. Once again, warmest round of gratitude to all parties who have made this webinar a great success. Thank you, and we hope to see you at the next webinar.